Welcome to the Pediatric Case Review Channel's comprehensive lecture on beta thalassemia. This presentation is designed specifically for healthcare professionals and clinicians. We will follow a case-based approach integrated with evidence-based content, covering genetics, pathophysiology, clinical manifestations, diagnosis, and management strategies. This comprehensive review will help you understand the full spectrum of this important hematological disorder. Question 1. Which of the following regions has the highest prevalence of beta thalassemia? Option A, Northern Europe. Option B, Mediterranean region. Option C, Central Africa. Option D, North America. Please consider your answer carefully as we explore the global distribution of this important hematological disorder. The correct answer is B, Mediterranean region. Beta thalassemia is most prevalent in the Mediterranean region, Middle East, Central Asia, India, and Far East. In these endemic areas, carrier rates range from 1 to 20%. Approximately 1.5% of the global population carries beta thalassemia genes. Migration patterns have contributed to the spread of this condition globally. The other regions listed, Northern Europe, Central Africa, and North America, have significantly lower prevalence rates compared to these endemic areas. Question 2. Beta thalassemia is inherited as Option A, autosomal dominant disorder. Option B, X-linked recessive disorder. Option C, autosomal recessive disorder. Option D, mitochondrial inheritance disorder. Consider the inheritance pattern carefully as this has important implications for genetic counseling and family planning. The correct answer is C, autosomal recessive disorder. In beta thalassemia, both parents must be carriers for a child to have beta thalassemia major. When both parents are carriers, there is a 25% chance of having an affected child, a 50% chance of having a carrier child, and a 25% chance of having an unaffected child. The condition is located on chromosome 11 and affects the beta globin gene. Over 300 different mutations have been identified in the HBB gene. The other inheritance patterns are incorrect because autosomal dominant would require only one affected parent, X-linked recessive primarily affects males, and mitochondrial inheritance is passed only from mothers to all children. Question 3. The primary defect in beta thalassemia is Option A, increased alpha-globin chain production. Option B, reduced or absent beta-globin chain production. Option C, structural abnormality of hemoglobin. Option D, defective heme synthesis. Consider the fundamental molecular mechanism that leads to the clinical manifestations of this disorder. The correct answer is B, reduced or absent beta-globin chain production. In beta thalassemia, mutations in the beta-globin gene lead to reduced or absent synthesis of beta-globin chains. This results in a relative excess of alpha chains, which cannot form normal hemoglobin tetramers. The unpaired alpha chains precipitate within erythroid precursors, causing membrane damage and leading to ineffective erythropoiesis in the bone marrow and hemolysis in the peripheral blood. This fundamental molecular defect explains all the clinical manifestations, including severe microcytic hypochromic anemia, bone marrow expansion with skeletal deformities, increased cardiac output, and extramedullary hematopoiesis. Question 4. A 2-year-old child of Mediterranean descent presents with pallor, failure to thrive, and hepatosplenomegaly. Laboratory findings show hemoglobin of 7 grams per deciliter, microcytosis, hypochromia, and target cells. The most likely diagnosis is Option A, iron deficiency anemia. Option B, beta thalassemia major. Option C, sickle cell anemia. Option D, glucose 6-phosphate dehydrogenase deficiency. Consider the age of presentation, ethnic background, and characteristic laboratory findings in your diagnosis. The correct answer is B, beta thalassemia major. This case represents the classic presentation of beta thalassemia major, which typically appears between 6 and 24 months of age with failure to thrive, pallor, and hepatosplenomegaly. The laboratory findings of severe microcytic hypochromic anemia with target cells on peripheral smear are characteristic. The Mediterranean ethnic background provides an important epidemiological clue. A key diagnostic feature is that the anemia is resistant to iron therapy, which helps differentiate it from iron deficiency anemia. The hepatosplenomegaly results from extramedullary hematopoiesis as the body attempts to compensate for ineffective bone marrow production. Question 5. Which form of beta thalassemia is characterized by moderate anemia and typically does not require regular transfusions? Option A, beta thalassemia major. Option B, beta thalassemia minor. Option C, beta thalassemia intermedia. Option D, delta beta thalassemia. Consider the clinical spectrum of beta thalassemia and the transfusion requirements associated with each form. The correct answer is C, beta thalassemia intermedia. Beta thalassemia intermedia represents the middle of the clinical spectrum, with severity between major and minor forms. Patients typically have hemoglobin levels between 7 to 10 grams per deciliter and may require transfusions occasionally during stress periods like infections or pregnancy, but do not need regular transfusions like those with beta thalassemia major. This form is often diagnosed later in life compared to beta thalassemia major and shows wide genotypic and phenotypic variability. The other options are incorrect because beta thalassemia major is characterized by severe anemia requiring regular transfusions. Beta thalassemia minor typically presents with asymptomatic or very mild microcytic anemia, and delta beta thalassemia is a specific genetic variant that may present as minor or intermediate, but isn't defined by the specific clinical feature of moderate anemia without regular transfusion requirements. Question 7. A 6-month-old infant shows hemoglobin of 8 grams per deciliter, NCV of 65 femtoliters, and NCH of 20 picograms. What would be the next best step for diagnosis of beta thalassemia? Option A, bone marrow aspiration. Option B, hemoglobin electrophoresis. Option C, iron studies. Option D, direct Coombs test. Consider the appropriate diagnostic algorithm for evaluating microcytic anemia in an infant. The correct answer is B, hemoglobin electrophoresis. For this 6-month-old infant with microcytic anemia, hemoglobin electrophoresis is the next best diagnostic step. This test reveals elevated levels of fetal hemoglobin and hemoglobin A2, with hemoglobin A2 levels greater than 3.5%, strongly suggesting beta thalassemia. In beta thalassemia major, the test may show complete absence of hemoglobin A. High-performance liquid chromatography is often used instead of traditional electrophoresis in modern laboratories. This test is reliable after 6 months of age when fetal hemoglobin has normally declined. Genetic testing can subsequently confirm specific mutations, and family studies can help establish the diagnosis. Question 8. Which organ is typically the first to show clinical signs of iron overload in regularly transfused beta thalassemia patients? Option A, heart. Option B, liver. Option C, pancreas. Option D, pituitary gland. Consider the sequence of organ involvement in transfusional iron overload and the clinical implications for monitoring and management. The correct answer is B, liver. The liver is typically the first organ to show clinical signs of iron overload in regularly transfused beta thalassemia patients. Early manifestations include hepatomegaly and elevated liver enzymes. Each unit of transfused blood contains 200 to 250 milligrams of iron, and since the human body cannot actively excrete excess iron, this accumulates over time. The liver shows the earliest signs because it's the primary site of iron storage and processing. Cardiac iron deposition occurs later, but is the most life-threatening complication, often leading to heart failure if not properly managed. Endocrine glands, including the pancreas and pituitary, are affected progressively, with pancreatic involvement leading to diabetes mellitus and pituitary iron deposition causing hypogonadism and growth failure. Question 9. A 4-year-old with beta thalassemia major has pre-transfusion hemoglobin of 8.5 grams per deciliter. According to current guidelines, what should be the target post-transfusion hemoglobin level? Option A, 9 to 10 grams per deciliter. Option B, 11 to 12 grams per deciliter. Option C, 13 to 14 grams per deciliter. Option D, 15 to 16 grams per deciliter. Consider the optimal transfusion strategy that balances efficacy with minimizing iron overload complications. The correct answer is C, 13 to 14 grams per deciliter. According to current guidelines, the optimal post-transfusion hemoglobin target for beta thalassemia major patients is 13 to 14 grams per deciliter. This target maintains pre-transfusion hemoglobin levels above 9 to 10.5 grams per deciliter and typically requires transfusions every 3 to 4 weeks. This regimen effectively suppresses ineffective erythropoiesis, which improves growth and development, reduces cardiac workload, and prevents skeletal deformities and organomegaly. Leukodepleted, phenotypically matched blood is recommended to reduce alloimmunization and transfusion reactions. Question 10. Which of these is an oral iron chelator approved for first-line therapy in beta thalassemia patients? Option A, deferoxamine. Option B, defersirox. Option C, desferrioxamine. Option D, deferiprone. Consider the route of administration and current treatment guidelines for iron chelation therapy in transfusion-dependent patients. The correct answer is B, defersirox. Defersirox is an oral once-daily iron chelator approved for first-line therapy in beta thalassemia patients. It offers the convenience of oral administration compared to traditional chelation therapy. Deferoxamine, also listed as desferrioxamine in option C, is the same parenteral medication that requires subcutaneous or intravenous administration, typically given over 8 to 12 hours, 5 to 7 days per week. Deferiprone, while also oral, is typically used as second-line therapy or in combination regimens due to its safety profile, including the risk of agranulocytosis. The choice of chelation therapy depends on multiple factors, including iron burden, presence of organ damage, patient age, and compliance considerations. Cardiac iron deposition requires specific chelation strategies, and regular monitoring of both efficacy and toxicity is essential for all chelation regimens. Question 11. A 14-year-old girl with beta thalassemia major presents with absent pubertal development. Which finding is most likely on investigation? Option A, primary ovarian failure. Option B, hypothyroidism. Option C, hypogonadotropic hypogonadism. Option D, adrenal insufficiency. Consider the pathophysiology of endocrine complications in transfusion-dependent beta thalassemia patients. The correct answer is C, hypogonadotropic hypogonadism. In this 14-year-old girl with beta thalassemia, major, and absent pubertal development, the most likely finding is hypogonadotropic hypogonadism. This occurs due to iron deposition in the pituitary gland, leading to reduced gonadotropin secretion. Hypogonadotropic hypogonadism is the most common endocrinopathy in transfusion-dependent beta thalassemia patients. Growth hormone deficiency is also frequently seen. These patients require hormone replacement therapy for proper pubertal development. Regular endocrine monitoring is recommended from early childhood, including assessment of growth velocity, pubertal staging, and hormonal evaluation at appropriate ages. A multidisciplinary approach involving endocrinology specialists is essential for optimal management. The other options are less likely because primary ovarian failure is less common than central hypogonadism in thalassemia patients. Hypothyroidism can occur, but typically doesn't cause absent puberty as its primary manifestation. And adrenal insufficiency is relatively rare in beta thalassemia compared to pituitary involvement. Question 12. What is the gold standard for monitoring cardiac iron overload in beta thalassemia patients? Option A, echocardiography. Option B, electrocardiogram. Option C, cardiac MRI T2* imaging. Option D, serum ferritin levels. Consider the most accurate and reliable method for detecting cardiac iron deposition before functional changes occur. The correct answer is C, cardiac MRI T2* imaging. Cardiac MRI T2* imaging is the gold standard for monitoring cardiac iron overload in beta thalassemia patients. This non-invasive technique can accurately quantify myocardial iron deposition before functional changes occur. A T2* value less than 20 milliseconds indicates iron overload, while values less than 10 milliseconds indicate severe overload. Annual cardiac MRI is recommended for all transfusion-dependent patients. This is particularly important because cardiac failure remains the leading cause of death in beta thalassemia. Serum ferritin levels correlate poorly with cardiac iron and may be normal despite significant cardiac iron deposition, making it unreliable for cardiac monitoring. Echocardiography can detect functional changes, but misses early iron deposition, while electrocardiogram changes typically appear late in the disease process. Early detection of cardiac iron through MRI T2* imaging allows for timely intervention with appropriate chelation therapy adjustments before the development of cardiac dysfunction, significantly improving patient outcomes. Question 13. A 10-year-old with beta thalassemia has increasing transfusion requirements, greater than 250 milliliters per kilogram per year, and massive splenomegaly. What is the most appropriate management? Option A, increased transfusion frequency. Option B, splenectomy. Option C, hydroxyurea therapy. Option D, stem cell transplantation. Consider the indications for splenectomy in transfusion-dependent beta thalassemia patients. The correct answer is B, splenectomy. For this 10-year-old with beta thalassemia who has increasing transfusion requirements greater than 250 milliliters per kilogram per year and massive splenomegaly, splenectomy is the most appropriate management. The primary indications for splenectomy in beta thalassemia include increased transfusion requirements and massive splenomegaly causing discomfort or functional impairment. Splenectomy typically reduces transfusion needs by 30 to 50%. However, this procedure is less commonly performed today due to improved transfusion regimens. The risks of splenectomy include increased susceptibility to infections, particularly from encapsulated organisms, and increased thrombosis risk. Patients require vaccination against encapsulated organisms and prophylactic penicillin therapy post-splenectomy. The other options are less appropriate because increasing transfusion frequency would worsen iron overload. Hydroxyurea has limited efficacy in beta thalassemia compared to sickle cell disease, and while stem cell transplantation is curative, it is not the first-line management for this specific indication of hypersplenism. Question 14. Which factor is associated with the best outcomes for hematopoietic stem cell transplantation in beta thalassemia? Option A, age greater than 14 years at transplant. Option B, presence of hepatomegaly. Option C, Class 1 Pesaro risk classification. Option D, alternative donor source. Consider the prognostic factors that influence transplant outcomes in beta thalassemia patients. The correct answer is C, Class 1 Pesaro risk classification. The Pesaro risk classification system is used to predict outcomes of hematopoietic stem cell transplantation in beta thalassemia. Class 1, defined by the absence of hepatomegaly, absence of portal fibrosis, and a history of regular chelation therapy, is associated with the best outcomes, with greater than 90% disease-free survival. Transplantation outcomes are best when performed before age 14, and HLA-matched sibling donors are preferred over alternative donor sources. This remains the only curative treatment currently widely available for beta thalassemia. Pre-transplant assessment of organ damage is crucial for determining suitability and risk stratification. Class 2 and 3 patients have progressively worse outcomes due to increased iron-related organ damage. Question 15. Which gene therapy approach for beta thalassemia received FDA approval in 2022? Option A, CRISPR/Cas9 gene editing. Option B, lentiviral vector-based gene addition. Option C, zinc finger nuclease technology. Option D, AV vector-based gene therapy. Consider the latest developments in gene therapy for hemoglobin disorders. The correct answer is B, lentiviral vector-based gene addition. In 2022, detabeglogene autotemcel, also known as Beta-cel, received FDA approval for transfusion-dependent beta thalassemia. This therapy uses lentiviral vector-based gene addition, where the patient's own stem cells are collected and modified ex vivo with a functional beta-globin gene before being reinfused. This represents a potentially curative one-time treatment approach. The therapy requires specialized centers for administration due to its complexity. While other gene therapy approaches are in development, including CRISPR/Cas9 gene editing, which is in late-stage clinical trials, the lentiviral vector approach was the first to receive regulatory approval. Additionally, luspatercept has been approved for treating anemia in beta thalassemia, though it's not a gene therapy. Despite these advances, accessibility and cost remain significant barriers to widespread implementation of gene therapies. Question 16. A couple, both beta thalassemia carriers, are planning pregnancy. Which prenatal diagnostic method can be performed earliest in pregnancy? Option A, amniocentesis. Option B, chorionic villus sampling. Option C, fetal blood sampling. Option D, non-invasive prenatal testing. Consider the gestational age at which various prenatal diagnostic procedures can be performed for genetic disorders. The correct answer is B, chorionic villus sampling. For this couple who are both beta thalassemia carriers and planning pregnancy, chorionic villus sampling can be performed earliest in pregnancy, typically between 10 to 13 weeks gestation. This timing allows for earlier diagnosis compared to other invasive procedures. Amniocentesis is performed later, between 15 to 20 weeks gestation, while fetal blood sampling is done after 18 weeks. Although non-invasive prenatal testing can be performed after 10 weeks, it is still investigational for beta thalassemia and not yet standard practice. Pre-implantation genetic diagnosis is increasingly available for at-risk couples. Population screening and genetic counseling remain key prevention strategies for beta thalassemia. Early diagnosis through chorionic villus sampling allows couples to make informed decisions about the pregnancy. Question 17. Which intervention has shown the greatest impact on improving quality of life in adolescents with beta thalassemia? Option A, frequent hospital visits. Option B, comprehensive psychosocial support. Option C, limiting physical activity. Option D, home isolation to prevent infections. Consider the holistic approach to managing chronic illness in adolescents beyond just medical treatment. The correct answer is B, comprehensive psychosocial support. For adolescents with beta thalassemia, comprehensive psychosocial support has shown the greatest impact on improving quality of life. This includes educational support with appropriate academic accommodations, peer support groups, mentorship programs, and structured transition programs from pediatric to adult care. Regular psychosocial assessment is recommended to identify and address issues early. Adolescence is a particularly challenging period, with poor treatment adherence being common. School and vocational support are critical for long-term independence. The focus should be on enabling normal life activities with appropriate accommodations rather than restrictions. Body image concerns and social integration issues are also important to address. The other options are incorrect because frequent hospital visits can actually disrupt normal life and schooling. Limiting physical activity is unnecessary with modern management approaches, and home isolation to prevent infections is not recommended and would significantly reduce quality of life. A comprehensive psychosocial approach addresses the unique challenges adolescents face while living with a chronic condition like beta thalassemia. Question 18. A 25-year-old woman with beta thalassemia intermedia becomes pregnant. Which of the following is most important in her management? Option A, termination of pregnancy. Option B, intensified transfusion regimen. Option C, discontinuation of all chelation therapy. Option D, avoidance of folic acid supplementation. Consider the special management considerations for pregnant women with beta thalassemia. The correct answer is B, intensified transfusion regimen. For this 25-year-old woman with beta thalassemia intermedia who becomes pregnant, an intensified transfusion regimen is the most important management strategy. Regular transfusions are recommended during pregnancy even for patients who are not normally transfusion dependent. The target hemoglobin level should be maintained above 10 grams per deciliter throughout pregnancy, which may require more frequent transfusions than her baseline regimen. This approach improves fetal growth and reduces maternal complications. While most chelation therapies are contraindicated during pregnancy, this is secondary to ensuring adequate hemoglobin levels. Folic acid supplementation is actually important and should not be avoided. Multidisciplinary management involving high-risk obstetric specialists is essential, with close fetal monitoring throughout the pregnancy. Question 19. Which of the following is most important in the preoperative management of a beta thalassemia patient? Option A, cardiac assessment. Option B, pre-transfusion to optimal hemoglobin. Option C, discontinuation of chelation therapy. Option D, Prophylactic antibiotics. Consider the potential complications and risks associated with surgery in patients with beta thalassemia. The correct answer is A. Cardiac assessment. In the preoperative management of a beta thalassemia patient, cardiac assessment is the most important consideration. Cardiac dysfunction is common in these patients and may be subclinical, meaning patients can appear stable while having significant cardiac compromise. Cardiac MRI T2* imaging should be performed if recent results are not available, along with echocardiography for functional assessment. Perioperative cardiac decompensation represents a major risk that can be fatal if not anticipated and managed appropriately. While pre-transfusion to optimal hemoglobin levels is also important, adjusting chelation therapy according to surgery type and recovery period, providing thromboprophylaxis for splenectomized patients, and multidisciplinary planning are all essential components of perioperative care. The cardiac assessment takes precedence because undetected cardiac dysfunction can lead to catastrophic outcomes during surgery. Question 20. An 18-year-old with beta thalassemia major is transitioning to adult care. Which approach is associated with best outcomes? Option A. Abrupt transfer at age 18. Option B. Structured transition programs starting in early adolescence. Option C. Continued care in pediatric setting until age 25. Option D. Patient-initiated transfer when ready. Consider the optimal approach for transitioning adolescents with chronic hematological conditions from pediatric to adult healthcare systems. The correct answer is B. Structured transition programs starting in early adolescence. For this 18-year-old with beta thalassemia major transitioning to adult care, a structured transition program beginning in early adolescence is associated with the best outcomes. The optimal transition process should start around age 12 to 14 with a gradual increase in self-management skills development. Joint pediatric adult clinic visits help build familiarity with the adult care team, and comprehensive medical summary transfer ensures continuity of care. Poor transitions are associated with treatment abandonment, increased risk of complications during the transition period, medication non-adherence, and loss to follow-up in the adult healthcare system. Question 21. According to the most recent Thalassemia International Federation guidelines, what is the recommended target liver iron concentration in transfusion-dependent patients? Option A. Less than 3 mg of iron per gram dry weight. Option B. Less than 7 mg of iron per gram dry weight. Option C. Less than 15 mg of iron per gram dry weight. Option D. Less than 20 mg of iron per gram dry weight. Consider the current evidence-based targets for iron chelation therapy in preventing iron-related organ damage. The correct answer is A. Less than 3 mg of iron per gram dry weight. According to the most recent Thalassemia International Federation guidelines, the optimal target for liver iron concentration in transfusion-dependent patients is less than 3 mg of iron per gram dry weight. This lower target reflects improved understanding of iron toxicity and the availability of better chelation options. The guidelines also recommend maintaining serum ferritin levels below 1,000 nanograms per milliliter and cardiac T2* values greater than 20 milliseconds. Annual comprehensive assessment is recommended for all transfusion-dependent patients. The guidelines emphasize personalized chelation regimens based on individual patient factors, with regular monitoring of iron burden being essential. MRI assessment of both liver and cardiac iron provides the most accurate evaluation of iron loading. Question 22. A 30-year-old with well-transfused beta thalassemia major complains of right upper quadrant discomfort. Initial workup shows normal liver enzymes. What is the most appropriate next step? Option A. Reassurance and symptom management. Option B. Liver ultrasound with elastography. Option C. Liver biopsy. Option D. Increase chelation therapy empirically. Consider the long-term hepatic complications in beta thalassemia patients despite normal biochemical markers. The correct answer is B. Liver ultrasound with elastography. For this 30-year-old with well-transfused beta thalassemia major who presents with right upper quadrant discomfort despite normal liver enzymes, liver ultrasound with elastography is the most appropriate next step. Patients with beta thalassemia have a significant risk of chronic liver disease even when liver enzymes are normal. This approach allows for non-invasive assessment of liver structure and fibrosis, while also screening for hepatocellular carcinoma, which is recommended in this population. The risk of viral hepatitis from historic transfusions before effective screening was implemented adds to the long-term liver complications. Non-alcoholic fatty liver disease is also increasingly recognized in thalassemia patients. Hepatitis B vaccination is recommended for all patients. Question 23. Which of the following is the largest contributor to healthcare costs in beta thalassemia management? Option A. Transfusion therapy. Option B. Iron chelation therapy. Option C. Management of complications. Option D. Diagnostic testing. Consider the economic aspects of long-term beta thalassemia management and the relative costs of different components of care. The correct answer is B. Iron chelation therapy. In beta thalassemia management, iron chelation therapy accounts for 50 to 80% of treatment costs, making it the largest contributor to healthcare expenditures. This high cost is due to the need for lifelong daily chelation therapy, which involves expensive medications, regular monitoring, and management of side effects. There is significant variation in access to optimal chelation therapy globally, with many patients in resource-limited settings unable to afford adequate treatment. Early intervention with appropriate chelation can reduce long-term complication costs, but the upfront expense remains substantial. Resource-stratified guidelines are needed for lower-income regions to provide the best possible care within budget constraints. The cost-effectiveness of curative therapies like stem cell transplantation and gene therapy is under evaluation, as these may prove more economical over a patient's lifetime despite high initial costs. Lifetime costs for transfusion-dependent patients are substantial, and prevention programs have been shown to be cost-effective in endemic areas. Public health planning is essential for sustainable care delivery. While transfusion therapy, management of complications, and diagnostic testing all contribute significantly to overall costs, the high expense of lifelong chelation therapy makes it the largest single cost component in most healthcare systems. Question 24. Two siblings with identical beta-globin gene mutations show significantly different disease severity. Which factor most likely explains this difference? Option A, gender differences. Option B, alpha-globin gene co-inheritance. Option C, age difference. Option D, variability in iron absorption. Consider the genetic modifiers that can influence the clinical phenotype in beta thalassemia beyond the primary beta-globin mutation. The correct answer is B, alpha-globin gene co-inheritance. When two siblings with identical beta-globin gene mutations show significantly different disease severity, alpha-globin gene co-inheritance is the most likely explanation. Alpha thalassemia trait reduces the alpha/beta chain imbalance that is central to beta thalassemia pathophysiology, leading to a milder phenotype. Other important genetic modifiers include HbF modifiers such as BCL11A and HBS1L, MYB, which affect fetal hemoglobin production and can ameliorate disease severity. The XMNI polymorphism is another genetic variant that increases HbF production and is associated with milder disease. Understanding these genetic modifiers is increasingly important for prognosis and treatment planning. These modifiers are also becoming targets for novel therapeutic approaches. The knowledge of genetic modifiers helps explain the phenotypic variability often observed within families carrying the same primary beta-globin mutations.